screen is also visible.
We'll start.
Yes, sir.
Vismay, give and we go live.
Yeah. So we are live in 3, 2, 1. So we are live now. Please start.
Hello and welcome to all this audience to our e-Gurukul from Dr. P.C. Mohapatra, our renowned gynecologist and obstetrician, a master of his subject, and I think no better teacher than him is there, which we have experienced. So he's a teacher par excellence and a very good human at heart also. So today we would like to continue with our series of 6 episodes, out of which today we will be having further gain of our knowledge in surgical skill transfers and solving the clinical dilemmas. And the topic for the day is very interesting, and that is the management of myomas of uterus. So Dr. P.C. Mohapatra will launch this particular session. Today, coincidentally, there was a good launch of PSLV also from our ISRO, and that was very successful. So I think this session will also be similarly successful, and you'll all enjoy this session. I hand it over to Dr. P.C. Mohapatra. Sir, please.
Thank you very much, Dr. Diwan and Team Zuventus for this giving me this opportunity of the educational program of e-Gurukul, a Zuventus initiative. And we have previous episodes we have discussed about one particular topic on cesarean section. And today I want to bring a new topic and a very common topic of concern, particularly for the gynecologists and obstetricians in particular. And there are many controversies involving around this particular subject of myoma uterus and the management, with special reference to the changing strategies, changing techniques, and then changing steps of different procedures. And I thank you very much. I welcome all the viewers and my beloved gynecologist, my beloved friend, philosopher and guide, my students, my teachers, my colleagues, and everybody for this e-Gurukul program. I bring greetings from the place of Lord Jagannath and welcome to e-Gurukul Obstetrics and Gynecology. Is the video seen, Devan? Is the video? My audio is absolutely normal?
Yeah, audio is absolutely normal, sir. And we can see
my
the
slides are visible?
Yeah, slides are visible, sir.
Yeah. So my viewers today will be particularly dealing with the myoma, management of myoma uterus. And there are many dilemmas around the treatment of myoma uterus. Whether you treat or not to treat is a point of controversy. And unnecessary surgery has been done, unnecessary medication has been done also. We will discuss all these. And some of the videos, demonstration of my own surgery of various types of myomectomy, tips and tricks I will demonstrate in this particular. And Dr. Diwan, I am not at par with the launching of ISROs to that standard, but at least I'm a teacher and teaching is a passion for me. And that's why I will try my best to share my, whatever I know, I should share and transfer to my next generation so that the science will grow and grow.
This is you, the humble one. So we all bow down to you.
Thank you. Thank you. So myoma uterus, I think a general discussions on the myoma uterus, we know every gynecologist day in and day out in their practice, they see that is one of the commonest benign condition in gynec practice. And I'm sure every one of you must have seen at least one myoma per day in your OPD patients for that. It has a wide spectrum of presentation, starting from menstrual abnormality to perception of lump, to some pressure symptoms of acute retention of urine, to infertility and pregnancy loss, and of course, many complications, and out of which emergencies could be there if there is any complications for that. So it has a wide spectrum of presentation for that. And mainly we know that myoma is mainly seen in the reproductive age group. And from adolescent to geriatric populations, I think it's there, but still we find in adolescent group, it is not limited to only reproductive age group after marriage, but before marriage also, particularly in adolescents, we can see a number of myomas, which are a deep concern for them, for their mother, for the reproductive potential for that. And of course, if the geriatric age group post-menopausal myoma is really a concern, as far as we are really worried about the myoma developing after the menopause, because we know that myoma is a disease which is related to some hormonal factors like estrogen and progesterone play a very great role in the pathogenesis and growth of myoma. And therefore, it is absolutely logical or absolutely convincing to believe that in after menopause, the shrinkage of the myoma will be there. So that could be there. In rare cases, we get a geriatric population with the myoma uterus, which either persists or if it grows. If it grows, then suspicion arises if it converts into sarcomatous degeneration for that. So the pathogenesis, coming to the pathogenesis of the myoma, the origin of myoma, still we do not know where from the myoma arises. When we were students, we were being taught that it arises from the smooth muscles of the uterus. Then the different theories have disproved this, that it is not from the smooth muscle of the uterus. It arises from the smooth muscles of the arteries inside the uterus, arteries and arterioles inside the uterus. The muscular coat of the vessels give rise to that. But still, we know that there is a muscular component and a fibrous component, and therefore we call it a fibroleiomyoma. And there are many terminologies which is there, like starting from Okitansky to Virchow to many new generations for that also. But till date, we do not know. But however, it is accepted that it origins from the smooth muscles. The rate of growth. There is a lot of literature which shows that the rate of growth. Can we predict the rate of growth is not constant in one individual? It varies from patient to patient when we do not know the rate of growth, whether this particular dimensions will grow 1 centimeter per month or 1 centimeter per year or not. That is variable from individual patient. About the fertility relationship, we do not, there is again a controversy about the relation with fertility, because the size, even we have seen, all of you must have seen pregnancy with multiple myoma, even large size multiple myoma, 8 weeks pregnancy with a 20 week size uterus. That is also seen for that. And relation with fertility, in fertility practice, we see myoma. When we see infertility patients, we see the myomas, the detection of the myoma either by sonography or by laparoscopy for that. So it is very difficult to correlate and find out the plausible correlation between fertility potential and the myoma, although the site, the size matters for the fertility potential for that. And this is ill understood till today. It is most often medically and surgically abused. There are surgically abused, even if you find that resist from surgery. I will always resist the endoscopic surgeons from doing myomectomy when we see that. We must find out the reason for that. If the myomectomy helps it for the benefit of the patient, either reduction, either promoting the fertility or relieving the symptoms, I think it's good. Otherwise, most often we find presence of myoma, removal is not the answer for that also. And therefore, we must decide whether treat or not to treat. And that's $1 million question at times. Similarly, medically also, we have a lot of advances in medical management and some of the non-surgical methods, which I will eliminate in my discussions for that. And today, in the era of minimal invasive surgery, I think the conservative surgery and minimal invasive surgery is the really a dominant accepted norms today. And organ preservation, era of organ preservation, we don't go for radical surgery. We are coming for the conservative surgery and minimal invasive surgery for that. Now, there are various controversies in the various types and the points in which the classification type. The classification, when we were students, there was a classified uterine, extrauterine. And when we come to the uterine, classically the submucous, interstitial, and subserous are the 3 different types which you find out. But after the FIGO recently has given a relevance to the grading of a 0 to 8 grading of myoma. If it is a 0, completely submucous, and then 1, 2, 3, 4, up to 8, which is completely subserosal fibroid, pedunculated fibroid. So this has some relevance to the treatment modalities, because this is very, very important whether to treat and which method you have to do a myomectomy for that also. That will give an insight for that. Regarding the diagnostic criteria of a myoma, apart from the history and clinical examination, the enlargement of the uterus, the asymmetry, and the symptoms presenting with the menstrual problem or pressure symptoms or perception of lump abdomen. There are two methods which is very important. Sonography, of course, is a common method of diagnosis and non-invasive methods of diagnosis. And sonography can diagnose myoma, but don't expect that it can diagnose 100% of the myoma for that. I will give a caution when myoma, at times many patients, when we do, all of you must have experienced that thinking that this is a case of myoma by sonography, you are planning for a myomectomy, and during this surgery you find that this is not a case of myoma, it's an adenomyoma for that. So that is the only differentiating point between adenomyoma and myoma. Myoma classically is a hypoechoic lesion by sonography, encapsulated, everything could be there also. But there are some distinguishing features. At times it becomes very difficult to diagnose and differentiate between localized adenomyoma. And therefore, in the localized adenomyoma, differentiating point could be very accurate by MRI. So MRI can determine the junctional zone, and the demonstration of the junctional zone can differentiate myoma from adenomyoma for that. So when there is a suspicion, and particularly when we are going for a myomectomy, and in a case of fertility promoting surgery, I believe that MRI can help to a greater extent and plan it before surgery for that also, and then decision making during the time of operation. Now, association of myoma. We know that myoma is hormone dependent and related to estrogens for that, and therefore associated pathology could be there. And two important pathology, endometriosis and carcinoma endometrium or hyperplasia. Endometrial hyperplasia, carcinoma endometrium, and endometriosis are very well associated with the myomas. So in the particular predictive situation, particularly in elderly age group, when we find or symptoms of endometrial pain is found, dysmenorrhea is most often found for that. We think of adenomyosis, but dysmenorrhea in a case of myoma is more often found when there is a coexistent endometriosis for that also. So myoma and adenomyoma, clinically differentiating features, that adenomyoma give rise to dysmenorrhea, but myoma doesn't give rise to dysmenorrhea unless it is a polypoidal, I think it is protruding from the cervix like myomatous polyp for that. But here, when there is an associated endometriosis, it will have the dysmenorrhea for that also. And these are the associated pathology which you must concern, every clinician must be concerned for that also. Now, a few controversies about the recurrent myoma. There are some myomas who are very, very recurrent. In one particular case, you do a myomectomy and again it has recurred for that also. This recurrent myoma, that particular patient is more susceptible to the development of the myoma, and we find that recurrent myoma is a concern. How many times you do a surgery and how many times you give a optimum treatment for that also. Caesar and myomectomy, it was again yesterday's contraindications, is today's indication. I have elaborated in the last episode about the caesar and myomectomy, and I believe I'm a strong proponent of doing a caesar and myomectomy whenever myoma removal is really necessary and there is a genuine indication of doing a myomectomy in that particular. And don't do all cases, but invariably when these myoma need to be removed, they can be removed during cesarean section for that also. And I will again just highlight few of my slides and videos for that also. Now about the myomectomy, Bonnie, I think I must salute the main surgeon Bonnie, and Bonnie is famous for a myomectomy surgery, and his own instruments, myomectomy, Bonnie's myomectomy clamp, and the conventional surgery they have done. And for all the years, decades, our teachers and we also were adopting the conventional method of abdominal myomectomy for everything. And when the era of minimal invasive surgery has come out, I think the two main approach has been tackled for a myoma: laparoscopic myomectomy and hysteroscopic myomectomy. Laparoscopic myomectomy, there is a lot of changing trends and changing techniques, starting from the camera vision, starting from the vision to the dissection and suture particularly. there is a lot of change. And I will deal with that, particularly what are the changing trends and changing techniques for that. Laparoscopic myomectomy and hysterectomy myomectomy. When there is a submucous myoma, I think that's a very important thing, that we can deliver do a myomectomy from the hysteroscope, and that is a rewarding surgery and particularly helps in recurrent, I think, pregnancy loss, or in a case of infertility, this can be a rewarding surgery for that also. And that is really a boon and a development and update from the technological gift to change the situation of myomectomy. Now, what happens to the fate of abdominal myomectomy? Whether in the present scenario of increasing dimensions and spectrum of minimal invasive surgery of hysteroscopy and laparoscopy, shall we abandon the procedure? Shall we say that abdominal myomectomy should be going to the graveyard? No, I must say that it has a place, definitely. Number one, one must be competent enough to do an endoscopic myomectomy. That's one. Second, the gadgets must be available and technology must be there, particularly there. And Indian scenario, particularly, this is not possible in all cases. So every gynecologist are not, I think, cannot do by skill also or by technological deprivation. They cannot do all these. And whatever is best, they can do. There is a place for abdominal myomectomy also. And some cases where don't do endoscopic, don't show your skill, endoscopic skill by doing a case which is unindicated, a very large myoma. Don't take a credit of doing it at the cost of the patient. Remember, one, for the benefit of the patient, if the patient gets benefit out of it also, then you can do an endoscopic approach. Otherwise, there is a place in a huge myoma where endoscopic procedure will cause more harm. Don't do it. I think abdominal myomectomy has a place in the era of minimal invasive surgery, in my opinion. So it cannot be a dogma in science where you individualize that particular patient and then decide whether you are skillful enough to do it, or the patient's condition or the patient's profile is suitable for an endoscopic procedure. Otherwise, there is no harm in doing an abdominal myomectomy for that. Now, coming to the shift to medical management. Medical management has really changed the situation, particularly in a myoma and recurrent myoma in particular. New molecules have come out, like ulipristol and mifepristone. These are the two molecules which were there. People thought that, yes, when ulipristol came, ulipristol acetate is a wonder molecule for myoma. Believe me, it's not a wonder molecule for myoma. It's one of the medical management. And previously, when it was not available, we're using the GnRH analog, which reduces the bulk of the myoma, size of the myoma to a considerable extent, but it's a temporary thing. It's not a permanent thing. Again, after a few months, it will again come back for that also. So ulipristol and mifepristone has been tried for that, and safety, dose, duration are various. I think today we'll discuss about the surgical aspect, but there is a place for ulipristol and mifepristone, medical management of myoma. There is definitely a place, and this can have really an alternative to a surgical methodology for that. Now, some of the other non-surgical methods like uterine artery embolization. The interventional sonologists have devised a uterine artery embolization. We know that the vascular supply, if you cut it, and then the myoma growth ceases. And therefore, this was the concept led by uterine artery embolization. But there could be a selection of the cases. A typical peculiar, I think, some category of patients are suitable for the uterine artery embolization for that. And therefore, they can do it in the properly selected cases, not in all cases for that. And earlier, the uterine artery embolization was not indicated in unmarried girls or in patients who want a pregnancy, because the uterine artery embolization will cause the reduction of the fertility potential. But now it has been disproved by many of the studies that yes, it could be an indication for that. It doesn't have fertility, I think the problem in fertility and augmentation, if not facilitating augmentation, it doesn't prevent the fertility for that. Now, MR focus ultrasound, there is a value of that, but it's a very costly equipment, and very rare centers have done this MR focus ultrasound and pinpoint that. But it is not, it is a particularly suitable, particularly for a single or it's never can be a multiple myoma. It is not at all suitable for that also. And again, MR focus ultrasound in repeated sitting, the chance of recurrence is also a factor for that. last but not the least, the controversies and consensus about power morcellator. The power morcellator was there till the American Court of Law. They abandoned the procedure with the case, and therefore Johnson withdraw the morcellator from his market for that. But still, it's a question of debate. Now, after that, the AAGL and other authorities, and including the gynecology, I think our IAG also have given a views of different studies that just by that case, I think you cannot abandon the procedure for that power morcellator. After that, lot of people have devised so in-bag morcellator and all that. They're still using it in-bag morcellator, but in my view, it cannot be abandoned. Power morcellator cannot be abandoned for that. And people have used either in-bag or delivering the myoma through the cul-de-sac. I think these are the two alternatives for that. But these are all controversies and consensus. The basic philosophy is that the sarcoma and myoma is now proved that the gene is completely different. The origin and the pathogenesis is completely different. The myoma undergoing sarcomatous degeneration is very, very rare. But sarcoma develops from the beginning and all that. That's all right. But even if you believe that this is the sarcoma, the clinical profile of the patient, rapid growth of the patient, the myoma, the recurrent lesions, the sonographic appearance, and particularly the color Doppler showing the vascularity, that will aid it. And screening and diagnosing this sarcoma before the surgery is more important. Otherwise, the power morcellator still is a question of debate, where many of the debatable issues have been solved. Maybe that in future we will be able to solve all the issues of power morcellator models. Now, coming to the clinical situations. Now, let us discuss about the clinical scenario and solving clinical dilemmas, how we do that. This is number one, a case of primary infertility, 4 years with oligoasthenospermic male factor, and sonographic evidence of Myoma Uterus, and one diagnostic histolaparoscopy. You find I have given 3 different cases where this is a case where there is a subserous myoma here. This is a case where there is a subserous myoma on the posterior surface, and this is a case where the subserous 3 subserous myomas on the anterior and posterior surface. These are the cases where the cavity is absolutely normal. Hysteroscopic, there is absolutely a normal cavity, and on laparoscopy, subserous myoma of 2 to 3 centimeters. I think this particular decision, what will be the decision factor, whether myomectomy you do it or something. There are some special things to note. Attribute to fertility. Can you say that this myoma is responsible for infertility? So attribute to fertility potential. Can you say that need for surgical intervention? Can you say that the studies, whatever has been there, even on removal, it doesn't bear to the fertility. Rather, it can aggravate, it can really deteriorate the fertility potential in form of the post-operative adhesions, and the pelvic factor could be there for also. So that is a rational treatment has to be done, and you must find treat or not to treat is a major thing here. You have to decide. Decision is more important than dissection. And repeatedly I'm telling, don't do any harm, if not benefit to the patient for that also. If you are tackling, if you are doing showing your surgical skill, you can get a real deterrent for that fertility potential. I have seen many patients being treated with that, and they're really the end of the fertility story, and they have to go for ART procedures for that. And therefore, the message is that think of other causes of infertility, evaluate and treat, and then only you can find out. Cavity evaluation is a strong predictor. If the cavity there occurs a submucous myoma, that is indicated for hysteroscopic myomectomy. But if the cavity is normal, other causes of infertility evaluate and find out. The site, the size, the nature have a relevance to fertility potential for that. And accuracy and interpretation of sonographic findings to be critically analyzed for that. Then another case. Now P1, para 1, spontaneous vaginal delivery, normal cycle, master health checkup. Now the era of master health checkup by corporate hospital, and on sonography they found revealed 2 myomas, and the radiologist always report in form of millimeter, 20 millimeter and 15 millimeter diameter. The patient gets an impression that it is a 20 millimeter myoma and 15 millimeter myoma, and the radiologist in their opinion say that is not to be clinically correlated, and it's not for legal purpose for that also. And patient has said that I have got two myomas, two tumors in my uterus for that. And that becomes a panicky for the patient. And what is the clinical approach? Implication of sonography report, need for treatment, and this is a problem of master health checkup. If go for a master health checkup, if you are not diseased, you are well, you become ill for that also. And with the simple report of investigations, one is not proved to be diseased. And therefore, as a teacher for last 40 years, this is my impression, that it will take me 1 year to teach how to do surgery. It will take me 5 years to teach when to do surgery. And it will take me lifetime to teach when not to do surgery. I think that decision and dissection is important. When not to do surgery, you should know. And here are again 3 examples I have given, that these are the cases. You don't do surgery. There is no indication of surgery. Even if there is a myoma uterus, and treat or don't treat, you have to decide for that. Now, this is a case where 24 years, there is a previous 2 abortions, both first trimester abortion at 10 to 12 weeks. Cycle was regular, cycle was menorrhagic, Hoppla negative. And what is the finding on hysteroscopy? Hysteroscopy is a must as a cavity evaluation for that. And this is a cavity evaluation where you find a beautiful submucous myoma, 2 beautiful submucous myomas in the cavity. And it's expected that these are the cause of the abortion for that. And this hysteroscopic myomectomy could be a rewarding procedure for this type of cases. And diagnosis is hysteroscopy, or if you can go for a sonography and diagnose this particular case, or a contrast sonography, or sonography with a contrast medium. Just give a saline and then do it. Contrast sonography can identify the submucous myoma like a polyp, and the treatment is particularly hysteroscopic myomectomy. This is very, very important. And even if it's a 1 centimeter myoma with the pregnancy loss, this could be a definite cause for a pregnancy loss. And therefore, transcervical resection of myoma is a rational procedure. In a big myoma, suppose this is a small myoma, you can do in 1 sitting. In a big myoma, depending on the size, it cannot be done in a single sitting because there are risks of hysteroscopic procedure because of the fluid overload for that. And therefore, even we can do for a multiple sitting or reduction of the myoma by giving a GnRH analog prior to that, you can do it. Even if you do a multiple sitting, there is no harm in that. And therefore, this is a very rewarding surgery for that. Pre-op preparation can be done, precaution for endometrial damage. Now, people have found if there are multiple myomas and large myoma, there could be endometrial damage, which can give rise to infertility or synechiae particularly. But be cautious about it. Don't do an undue damage for the endometrium, and do a check hysteroscopy after the procedure about 6 to 8 weeks after that. And subsequent follow-up and treatment are absolutely necessary. You see, this is one example. This is a surgical video of myoma uterus and a submucous myoma uterus. I think this is a grade 0. Completely found that all components which can be correlated with that. And we are doing with that the loop, the same loop as done by urologists. The same instrument as used by urology for prostate surgery is just like that same procedure with the medium of either if you are using earlier we are using the unipolar electrode, unipolar resectoscope, where we are using a glycine, but the glycine toxicity could be much more fatal, and therefore nowadays we have changed from unipolar to bipolar, and bipolar we can do it with the normal saline for that. But remember, even normal saline, we can say that you are using the instead of a glycine, if you are using the normal saline, it is safe. It is safe that glycine toxicity will not be there, ammonia toxicity will not be there, but you cannot rule out fluid overload because it is a vascular tumor. Under pressure, you are distending the uterus, and definitely there is a chance that some of the fluids can be absorbed systemically, and therefore that can give rise to fluid overload. Acute pulmonary edema can be seen here. So therefore, you must monitor regulate, and you must judge the amount of fluid which has gone inside. So the fluid maintenance chart, intake output chart has to be maintained, whether you are using the glycine or whether you are using the saline. In a glycine, the standard rule is that above 1000 ml, stop the procedure. Be very careful. You cannot go for more than 1.5 liters. If you're going for more than 1 liter, be careful that there could be a glycine toxicity. But in a case of saline, I think bipolar electrode, when you're using the bipolar resectoscope, there is a chance that there cannot be a ammonia toxicity, but use of the normal saline absorption through a vascular tissue. I think you open up the vessels after doing a resection, and therefore there can be the acute pulmonary edema. And therefore, you must say that the anesthetist will be very vigilant about this factor for that. If there's a slight suspicion, or you say that it's a very big uterus, a very big myoma, and it's taking a longer time, and therefore you stop the procedure at that particular level, you can repeat it in the second sitting, you can do it rather than killing the patient in the OT table. So the message is, space-occupying lesion is a common cause of recurrent pregnancy loss. Hysteroscopic procedure and resection is a rewarding result for that also. And then the next case, myoma, as I told, that adolescent, we think that adolescent girls normally present with abnormal uterine bleeding, and majority of the cases we see that it's a case of the hormonal disorder, like functional, like we say the palm-Cohen classification of abnormal uterine bleeding. We say that palm is a functional structural lesion and Cohen is a non-structural lesion. Majority of the adolescent, we think that is a non-structural or a Cohen, which is there for. But even with that, we treat with the hormones and it doesn't get resolved. And even with the investigations of myoma, the sonography and all that, you can find an adolescent small to big myoma for that. If it is a palpable per abdomen, it is obvious. But maybe that it carries a small submucous myoma presenting with persistent menorrhagic cycle, not amenable to medical management. You put a hysteroscope and found this, that this is a case where we do a vaginoscopic approach for that. In an adolescent, we always do a vaginoscopic approach. You can see the external os. I think it is really having a kiss to your telescope, and then go gently inside without dilatation. You can find this particular large submucous myoma filling the whole of the cavity. And this is the case where we find that submucous myoma filling whole of the cavity, and it's amenable for hysteroscopic resection for that. Same thing here, we find another case, we go for that, negotiate with the telescope, and this is there. We usually go for a 3 millimeter or 2.9 millimeter telescope and go and find out inside without dilatation. You find a beautiful submucous myoma, and tons of progestogens is not going to solve and not going to treat that particular patient. This particular adolescent can be very well tackled with the hysteroscopic resection of this myoma, and she'll be completely all right for that. And there is a definite indication of this surgical. I will demonstrate again the procedure in a few cases. You have seen one surgical resection, and again we'll see, I will show you a few transcervical resection of the submucous myoma. So rationale of hysteroscopy should be there, the rationale of laparoscopy should be there. There is no I think views of doing a laparoscopic myomectomy of a submucous myoma. I think submucous hysteroscopic myomectomy for many regions is superior to laparoscopic myomectomy. If they is more than 3, 4 or 5 or 6 or 7 outside intramural, more towards the serous layer, I think there's amenable for laparoscopic myomectomy. And inside, when we go for a 0, 1 or maximum 2, we can go for hysteroscopic myomectomy. Even FIGO grading 2 will be difficult, but with the skilled hands, it can be possible for that. So place of pre-op medications, I've already told, GNR channel can be given. Rationale of surgery and type of surgery, preferably a minimal invasive surgery could be there. And you cannot think of other surgery other than hysteroscopic myomectomy for that. And need for follow-up and subsequent treatment is necessary. If there is a large myoma, you can have a repeat check hysteroscopy to confirm, or having a second sitting for that. So the message here, think of local lesions in adolescent UB not responding to hormones. Sonography and MRI, rational pre-op planning tool. Pre-op medications place in reduction of size and elevation of symptoms, bleeding particularly, and non-surgical options, still controversial for that. And MIS is definitely a place, and I must say, particularly in this particular case, no second option is there only hysteroscopic myomectomy is really the answer for that. Now, this is a case of 30 years, primary infertility 4 years, normal male factor, menorrhagic cycle with the dysmenorrhea, uterus is 18 weeks, sonographic evidence of myoma uterus of about 20 centimeter diameter. The approach is there. I have already told, if you are skillful, endoscopic surgeon is there, you can go for a laparoscopic myomectomy with 18 week size uterus. There is no harm in that. But if you are not skillful or the gadgets are not available, you can go for an abdominal myomectomy. But myomectomy is necessary because it's a case of 18 weeks myoma with menorrhagic cycle and infertility. This type of myoma, definitely we can say that it has a relationship with the fertility. And doing a myomectomy can augment fertility promotion for that. And therefore, as far as indication of myomectomy, I think this is a suitable case for myomectomy for that. On the other side, you can see here the steps of laparoscopic myomectomy. I've given a transverse incision, and then with the, you have to go to the correct space, correct. I think cleavage is important. Otherwise, if you're not going to the cleavage, it's very difficult. And before that, you have a hemostasis of vasopressin injection, and doing that, vasopressin is a very good drug for hemostasis, but you have to be very vigilant. You ask the assistant, the anesthetist, that we are giving a vasopressin, and there is a tendency of bradycardia, and it's a simple measure. If we prevent it by giving the atropine, I think this is very important for that. Appropriate immediate detection is important. Otherwise, it could be very fatal for that. And therefore, then we can use it either with the tenaculum, laparoscopic tenaculum, or with the myoma screw, and gently through the first, the cleavage is important. You go gently and slowly you remove. And this is a myoma separator. I've used the other cases with the myoma separator, and this myoma separator, and keeping the, this is a tenaculum and the myoma separator. Combiningly, this is there, and myoma separator, I think completely avascular, and hardly there is a bleeding in a case of this myoma for that. And this myoma separator, I must say that it's a indigenous. It is manufactured by Indian company and Indian innovation for that myoma separator. And this is the harmonic, can use it for better appreciation, hemostasis, and really this is a beneficial instrument for that. And this is a bed which is there. We usually, the same principle of Bonney, we adopt it. If there is another myoma, we use for the secondary tunneling incision. This is a secondary tunneling incision rather than putting another incision. Laparoscopic secondary tunneling incision, the second myoma can be enucleated. Then the dead space should be, we don't enter into the, if you go carefully, the cavity is not opened, and therefore it's very well tackled, can be done by the laparoscopic procedure for that. And then the suturing, appointment of suturing. Gone are the era where the suture material was not available, even we are using the vicryl, and there the layered suturing was not very possible. It takes a lot of time, and suturing could be little skillful, and therefore interrupted sutures, multiple interrupted sutures, particularly in a case of the myoma uterus of vicryl, would be really cumbersome. And therefore, when the quill suture came, the barbed suture came, I think it's a boon for myomectomy. Big intramural myoma needs a closure in layers. It's not in one layers for that. You find the integrity of the scar in myoma scar, if you're not suturing in layers. But before barbed suture, it was just closed with one layer for that. Even skilled surgeon is difficult to close it for that. But after the barbed suture was available, after the technology the 3D camera was available, this myomectomy has become very, very popularized and very, very common for that. And average gynecological endoscopic surgeon can do the myomectomy, particularly large myoma also for that. But if it is not possible, you can do the same procedure by the conventional approach, by abdominal method for that. So these are some of the procedures for that. And after the suture, after the cavity, you must explore that there is not no other cavity, no other myoma is there. And it's very important that you suture it in layers, and that suturing in layers by barbed layer is possible. You give a continuous suture, one layer and second layer, and also they cover it with the serosal layer, so that the scar integrity could be much more better for that, as well as hemostasis could be really good, because the dead space are better approached and dead space are closed much better for that. So these are the cases where the myomectomy, laparoscopic myomectomy can advantage for that also. Now this is another case, 20 years old, unmarried girl. Normal cycle, perception of plump abdomen, uterus is 28 weeks, and sonography multiple myomas for that also. Every surgeon has a limitation of the size also. I can't dare for that. There could be the endoscopic surgeons who can dare for 36 weeks myoma, but I cannot dare for 36 weeks myoma. Size is the limiting factor for me as well as common gynecologist for that. And more so, these are all multiple myomas. The multiple myomas, I think you should not venture for the laparoscopic approach because he's unmarried, and the fertility potential is important for that also. And how far it is closer to the tube, and how many incisions you can give it, and how many you can deliver it, that's a big question mark for that. So need of surgery is there, but place of non-surgical intervention is not suitable for that. Here is a case where there are multiple subserous and intramural myoma, more of a subserous myoma, and here is very important that you can, if it's a pedunculated myoma, you can just coagulate the pedicle and then come out. You need not stitch it also. But here in the front, when we find this particular myoma can be coagulated, but this myoma, you have to just give an incision, remove it, and then suture it appropriately, keeping very much caution to the uterotubal junction. This is very important. Decision for the uterotubal junction is very important, and extreme care has to be taken that you don't disturb the anatomical relationship, and because this is important for fertility augmentation for that. So therefore, there is a place for abdominal myomectomy, as I've already told you, and you can do that. But the method, the surgical skill is important. How you do it, that is very important as far as the patient's fertility augmentation is concerned. For the proper cleavage is absolutely important to have less of bleeding. If you're not in a cleavage in myoma, you are gone for that. And therefore, when we are giving a incision, I always tell you just give a overcut, don't undercut. If you see an undercut, everything will look like a capsule and you are gone. So undercutting and overcutting, you can find that which is the capsule and which is not. And then after that, you cut little bit of myoma tissues, and then you can find the real cleavage, and therefore you can enter into the bloodless space for that. And again, suture it in layers, and then with the proper dead space closure, don't try to avoid the cavity. And this is what we always say. In the last case also, laparoscopically, I show in the open also you find secondary tunneling incision, and there could be many more myomas. With the same incision, you can find out for that. And remember, with the same incision, if you do it with other than multiple incision, the chance of adhesions are less, and fertility promotion will be more often encountered for the people. So the surgical techniques, these are some of the tips which I'm just mentioning about it. Now the message, myoma not uncommon in adolescent. Surgery is the mainstay. Fertility preserving techniques to be adopted. Adequate counseling and follow-up has to be done for that. Why I say follow-up and counseling for that? When we were students, normally we see in the books, standard books, our teachers were telling, in a myoma uterus, there are standard rules. When we're going for a myomectomy, you counsel the patient. What counseling? You counsel the patient that at any point of time, hysterectomy could be necessary. Then multiple blood transfusion is required for that also. Now, this has been changed. If a multiple blood transfusion is not necessary, standby is enough for that, and you have a control over the blood loss for that. So therefore, the multiple blood transfusion, I don't agree with that. Second, counseling, hysterectomy could be necessary. I got many of the patients being referred by doctors. Why you have come, unmarried girls? Because the doctor told that hysterectomy is necessary for that. So if you tell that hysterectomy is necessary in an unmarried girl and particularly infertility, who will adopt for that? So it's a negative counseling for that. You better counsel in a different way. And therefore, maybe that rarely, I have not remembered a single case where hysterectomy is required in my case. Maybe that God has helped me for that. And same technique, if you go do it, I think it's much more better for that. Now, this is a case again, a abdominal myomectomy. I can show you abdominal myomectomy in a very big myoma. This was a case where diagnosed as acute pain abdomen, and sonography demonstrated a lump, And abdominal examination also, we find about 30-week size uterus. But I planned it for the open myomectomy. And after that, I could find that it's a subserous myoma, and it could have been tackled with the laparoscope also. Big myoma, and it is a subserous pedunculated myoma. Laparoscopically could be amenable for treatment for that. But how can you diagnose that? It was not diagnosed. It was diagnosed. The diagnostic confusion was there. But however, we did this case with the abdominal thing, and then the small pedicle could be sutured for that. So this is one of the indications where we can do it. But it's confusing, particularly at times when it comes with the pain abdomen. Some of the complications of the myoma could be there, like a torsion and other. This is a case which I have already demonstrated also. A primary gravida conceived following investigation for infertility, 10 years, known myoma uterus, 38 week, and presented with premature rupture of membrane. Taken decision for emergency cesarean section for fetal distress. Tom male baby was delivered. Posterior wall intramural myoma, big intramural myoma, posterior wall was found. You can see the big intramural myoma. I have already shown this type of cases, and we do an intracavitary myomectomy. Instead of a separate incision and doing a myomectomy, we go through the cavity, and then going through the proper cleavage with the myoma screw, you just remove this, and this could be a very rewarding procedure, and uneventful recovery could be there for that. Because once a large myoma, intramural myoma, you deliver it by opening, by giving another incision, the incision size will be more, dead space will be more. Whereas if you come through the cavity, the muscles will contract and the dead space is very less, and just suturing very little and closing the dead space is much easier from the cavity than from the outside. So this is very important. An intracavitary myomectomy I'm doing for last many decades, 1.5 decades I'm doing this intracavitary myomectomy and cesarean myomectomy. I'm really, when myoma surgery is necessary, I will not hesitate to do the cesarean myomectomy in that particular case. And the main benefit is that the second surgery patient is deprived of, and with a single surgery, with a single sitting, you can do that procedure for that. So you deliver the big myoma and close it with the dead space with that, and then complete the procedure, the uterine closure for that. That finishes. So I may say that intracavitary approach is much more. It is not applicable for subserous myoma. You cannot do a subserous myoma intracavitary approach. But when there is an intramural myoma, either anterior or posterior, you can do it. So gone are the era where the indication of cesarean myomectomy was only limited to two situations. This myoma situated in the lower uterine segment anteriorly, and second is subserous pedunculated myoma. Accepting this, there was an absolute contraindication of myomectomy during cesarean section. But now even large intramural myoma can be done safely without any difficulty. And the same procedure, I must admit that intracavitary myomectomy is a real rewarding procedure for that. So the message, yesterday's contraindications are today's indications, not only limited to subserous pedunculated myoma or anterior wall myoma in cervical region, as I have already told, it has a broader indication. Dead space closure is easier and bleeding is less, and why not adopt for that? Post-op complications is minimized for that. And it's a novel technique. I will advise all of you to try and give a feedback whether it's a good or bad for that, and you'll be really happy, and need for second surgery is avoided. Patient is happy and you are also happy for that. Now this is a case where 26 years old, primary gravida with 8 weeks pregnancy, general condition okay, uterus was 26 weeks. Sonography, intrauterine live pregnancy, 8 weeks with a large intramural myoma. She opted for termination of pregnancy because some of the doctors advise for termination. But remember, if such patients come in a primary gravida, particularly those who want a pregnancy, don't do a termination of pregnancy, then do a myomectomy and then plan for second pregnancy. It's absolutely rubbish. I think majority of the pregnancy with myoma, they go uneventful. And all of you must have, some of you must have seen that even large myoma, the pregnancy continues uneventful, and normal spontaneous vaginal delivery is also possible. And this particular case, unfortunately, gone for a particularly premature rupture of membrane, and then LSS was planned and breach presentation. So PROM it breach this particular case with the multiple myoma, and that's why cesarean section was done. And in the same sitting, cesarean myomectomy was done, and the problem was solved. But had it been the vortex presentation and a favorable presentation is absolutely normally, spontaneous vaginal delivery can be tried for that. And after the baby, sometime at your own comfort time with the patient and yourself, you decide for a interval myomectomy rather than doing the termination of pregnancy with that. So therefore, need for termination of pregnancy, I don't think there is a need. Type of ANC is the same ANC. You must convince and counsel. Maybe that with the fetal growth, the myoma may grow. She will have a mechanical, really difficulty patient, and you convince this, and patient will really be very happy with after the end of the procedure. So place of vaginal delivery is there. Precaution during seizure. So by virtue of myoma, you don't do a seizure. Cesarean section is not indication for myoma with pregnancy. But if there is a breach, if there is a malpresentations, which is very common, if there is some other obstetric intervention indication, then you go for a cesarean section for that. So the message is pregnancy with myoma, a common association. Continuation of pregnancy and uneventful outcome is a common phenomena. Invariably vaginal delivery occurs, and if at all cesarean section is indicated, do a cesarean myomectomy at the same sitting for that. And routine myomectomy during cesarean for all cases is still controversial, but still it's operation during all cases, routine myomectomy. I must say that admit that wherever this myoma is operable and need for surgery has to be there, then you remove it. Otherwise, just multiple settling myomas, you remove it during cesarean section will cause more problem for that. Now, this is a case. These are three different cases which I'm doing. One case is that just para 2 menometrorrhagia, not responding to progesterone. These are given, and this particular case, and this particular case was subjected to CT, MRI, and everything. And no gynecologist they had to put a speculum in there. And particularly in COVID era, telemedicine and all that, they don't do it. And when you put a speculum, we found the myomatous polyp, and just with an avulsion, you just deliver it, and then do a hysteroscopy and find out whether there is other submucous myomas present there or not. I think these are the cases where this is a really with a very minor procedure, with the minutes you can do it. But remember, don't put undue traction. You just put a avulsion, and myomatous polyp automatically slip out and all that. This is another case where you find that there is a myoma arising from the cervical lip, the posterior lip of the cervix. There is a myoma, and a big myoma is there, and you give an incision and then do a vaginal myomectomy. These are procedures of vaginal myomectomy, and it's a very rewarding procedure for that. And every gynecologist, being a vaginal surgeon, can do the procedure with really accuracy for that. There is no special skill required for that. And you give an incision over that area, find out again the good cleavage, and just with the myoma screw, remove the myoma and reconstitute the cervix. They reconstitute and push the cervix. There is no harm in that. And you can clearly do it. Any average gynecologist can do it. But remember, you should go to the proper cleavage for that. And proper cleavage you go so that the bleeding will be less. And then either with the cat's paw or with this is a cat's paw which I'm using it, and you just give a traction. Unlike the previous case where avulsion without traction, just avulsion rotated. But here you have a big myoma and arising from the posterior lip of the cervix. So therefore, you apply a cat's paw, or with the myoma screw, you just put a traction and again dissect it so that the big myoma arising from the cervical posterior lip can be. These are the cases where they give rise to bleeding, they give rise to pressure symptoms, they give rise to acute retention of urine. But unnecessary, this particular case, you cannot subject all. Otherwise, if the family is complete, many people do a hysterectomy. But what is the genesis? What is the need of a hysterectomy here? If this is enough surgery for that, with the main procedure of within 5 minutes the surgery is over, you just have a reconstruction of the cervix. This is another case I remember during the corona pandemic time I did it. This particular case was presented Rh negative and para 1 previous cesarean. They came with a continuous bleeding PV off and on for last 3 months, and hemoglobin was 5.2 gram, RH negative, and patient was subjected to multiple advice for a multiple blood transfusion and then going for hysterectomy in a 32-year-old and RH negative, of course, para one previous cesarean. When I found, and sonographically, you found that sonographically there is a myoma, cervical myoma, and when you find that there is a small, the myomatous tissue is visible in the endocervical canal, and with the simple procedure, of under anesthesia, of course, I did it with the TIVA procedure with the pentothal, and the whole myoma, cervical myoma, can be delivered through the vaginal route, and this myoma is out. Now, with the simple procedure, it can be out, and after that, bleeding is controlled. I give a parenteral iron, patient is discharged. No need of a hysterectomy, particularly for this particular case. So, therefore, diagnosis is evident clinically. Put a speculum. Routinely, a gynecologist is putting a speculum rather than from the history or from investigations or from gadgets. Don't give a treatment for that. Hormone abuse is common in this particular case. Treatment is very simple. With a total intravenous anesthesia, you can deliver the good within 5 minutes. It can be completed, and all gynecologists, every gynecologist can do it. It doesn't need more of skill for that, but the will should be there for that, and you can avoid hysterectomy in this particular case. So the message: detailed clinical evaluation is mandatory. Vaginal myomectomy or polypectomy, a very simple procedure. Think of presence of additional myomas and evaluate. You do a hysteroscopy and find out whether there is an additional myoma. Sonography can demonstrate other additional myomas in the uterus, particularly for that. Therefore, if it is there, then do a appropriate treatment. Otherwise, the patient is absolutely cured. And that particular case, after that, she is completely relieved of the symptoms for that. This is another case. 40 years old, para 3 menorrhagic cycle for 2 years. Clinical findings are okay. Normal pelvic findings, normal pelvic scan, normal hematological profile. And therefore, this case was thought that this is a dysfunctional uterine bleeding. No pathology was there. And hysteroscopy, even when that there is a small submucous myoma. If there is a small submucous myoma of about 2 centimeters also, it cannot be diagnosed. It may be that sonography is overlooked that, and sonographically diagnosis becomes impossible. They think that it could be a polyp. They think that endometrial hyperplasia, and you find that there is a submucous myoma for that. Now the treatment here in this particular case, what is the optimum treatment? Now here in this particular case, the counseling of the patient is required. Whether in the 40-year-old lady, completed family, the main problem is menorrhagic cycle. The option is either a conservative approach of doing a transcervical resection of myoma or a hysterectomy. If there are multiple myomas, other than this submucous myoma, there are multiple myomas demonstrated by sonography, I think hysterectomy could be a choice for that. Otherwise, if there is a single myoma and patients want some menstrual function restoration, and therefore this particular case can be treated with the transcervical resection of myoma and can be an option, a very good option for that. So therefore, need for surgery, type of surgery, conservative, radical, depending on the particular situation, pathology, as well as particularly the consent of the patient's condition. Whether they need, many patients want that, no, I want even if I completed family, I want my restoration of menstrual function till the normalcy. And role of hysterectomy, if it is there, if it is an additional myoma or a recurrence, you can go for that. And role of medical management in this particular case of submucous myoma is remote. You cannot solve the purpose for that. Now, this is another case. Mrs. G, 45 years old, para 2, both LSCS, menorrhagic cycle for 3 years, mid position uterus, mid position bulky, firm, restricted mobility, sonography evidence of multiple intramural myomas of 1 to 2 centimeters. Now here we see 45 years, previous to LSCS, multiple 1 to 2 centimeter myoma, and the patient is presenting with menorrhagic cycle. Hysteroscopy was there, cavity was normal. There is no submucous myoma, endometrium is proliferative. Now what is the option? Need for hysterectomy? Yes. If the sole purpose of uterus is procreation and creation of diseases, this has created diseases, so remove the uterus. This is by some gynecologist who needs a terroristic approach for that. But place for medical management, alternative management for that. There is a medical management is there because there are small myomas which can be there, need for hysterectomy. If it's all right, indication for that. But alternative methods can be used for that, like Mirena, like hormonal methods, and like the control of bleeding and all that. If it is there, you can plumb, because the risk of hysterectomy is also there with the previous 2 cesarean section. I think they are the 2 alternatives as per the discussion of the patient, as per the concern of the patient, desire of the patient. You have to take a decision for that. But the main thing is that there is a possibility, there is a scope of the other treatment alternative to hysterectomy. You convince the patient and then find it out. So the message: counseling is important, place of medical management is there, and think of alternative to hysterectomy. Not surgery is not the all cases you go for a surgery if you find a myoma. Hysterectomy could be a last resort for that. Now this is a 52 years old postmenopausal lady. Para 3, pain abdomen, sonography, intramural myoma of 4 cm diameter, clinical evaluation normal, pelvic findings normal. I think these particular asymptomatic. She is a endometrial thickness is about 5 millimeter, but intramural myoma of about 4 cm. She is completely asymptomatic, and color Doppler doesn't show evidence of increased vascularity. What will you do in this particular case? Seeing that postmenopausal 4 centimeter myoma, if it is asymptomatic detection, I think no treatment follow-up is necessary for that particular case. If the size increases, or if the patient presents with postmenopausal bleeding, with even a 2 centimeter submucous myoma, that needs a treatment for that. And therefore, treat or don't treat is a decision making is important for that. Need for follow-up of this particular patient is there. But many times in postmenopausal bleeding, we find that there is a submucous myoma or a polyp. In that particular case, whether to do a polypectomy or myomectomy or do a hysterectomy, I think the first method, you have to rule out the endometrial carcinoma. And therefore, histopathology of the endometrial hysteroscopy is a must. If a demonstration of the polyp or myoma can be differentiated, you do a endometrial sampling, and if endometrial sample is negative for malignancy, if it is a benign pathology, either you can do a hysterectomy or do a polypectomy or a transcervical resection of hysteroscopic myomectomy. That could be an option, even if it's a postmenopausal women for that. But remember, before biopsy, don't do it. If the biopsy is a mandatory thing, hysteroscopy is a mandatory thing in that particular case. But in an asymptomatic, just by checkup, mastoid checkup, we find a 4 centimeter myoma in the intramural component, I think there's no need of treatment. Follow-up is essential for that. So association of malignancy, if the malignancy is suspected or endometrial hyperplasia is there, then you can go for prevention of the malignancy, going for carcinoma. In that particular case, either hyperplasia or malignancy, you can have an appropriate surgical management. Otherwise, follow-up is essential for that. So the message: postmenopausal not immune to myoma, reduction in size expected in postmenopausal women, increased size vascularity, need for intervention, think of some malignancy changes for that. Need for follow-up is there in other cases. Now, this is a very rare case which I found out, and that typical case. There are some atypical cases which is found. 48 years old, para 2, previous 2 cesarean section. Underwent lap hysterectomy 2 years ago. 2 years back, I did a lap hysterectomy for multiple myoma uterus. And now she complained of pain on left iliac fossa. And when we find an ultrasound, we find hypoechoic circumscribed lesion of 12 centimeter in the left adnexal region, where left adnexa ovary is cystic. And there we find a hypoechoic, classically, typically the sonographic appearance of a myoma uterus for that. Then we plan for a diagnostic and therapeutic lab. We find the diagnostic and therapeutic. You can see the picture, the therapeutic, when laparoscopy, when you find a big form structure in the left adnexa above the left adnexa in the left iliac fossa, and then the vasopressin is given. You can see the procedure, how the typical cases of myoma is seen, particularly in this case. So that signifies that even if the myoma can arise from the other sides, other side in the pelvis, and therefore the broad ligament myoma and round ligament myoma are other factors. It is not that only uterus there is a myoma, which is a uterine myoma can be there, but because there are smooth muscles tissues in the pelvis from the other tissues like a round ligament, or in the peritoneum in the broad ligament, I think there could be a broad ligament myoma. And this is one example of such atypical cases after hysterectomy, post hysterectomy is there. But laparoscopically it is amenable. We did it, that particular case, and then you see that how we have gone to that particular cleavage and putting a myoma screw and giving a string. There is no very vital structures there, so that you are afraid of tackling it laparoscopically. And there's a myoma separator. This is a myoma separator, and you just separate the myoma with the traction with the myoma screw. It can come out very easily without any torrential bleeding, absolutely bloodless, because there is no major vessels there. But main thing is that you must go to the proper cleavage. That's important for that. And it's absolutely a myoma completely separate from the uterus. And in the beginning, doing a hysterectomy also, nothing was being visible. And see, the whole myoma can be, and histopathology confirmation of myoma after the procedure. It's very well tackled for that. And a big myoma of about 12 to 15 centimeter can be delivered by laparoscopy. And therefore, then the adnexes are being tackled. So this is one example where I'm giving the atypical case for that. So the message is atypical case following hysterectomy. It is unlucky gynecologist and unlucky patient mainly. But 2 hours after the 2 years after the surgery, I was saved. That after 2 years of surgery, if it would done 2 months after the surgery, then I would have been really guilty and should have blamed me for that. So this is possible. This is another case. Very, very atypical again. I've seen 50 years, para 2, both LSCS, history of myomectomy twice, recurrence. Then again recurrence, abdominal hysterectomy for recurrent myoma. Then there is a myoma in the lungs and lobectomy for a mediastinal myoma in the mediastinum. See the patient and the patients of the patient and the relatives. Pain abdomen persisting off and on, not relieved with medication. Sonography, CT, MRI, non-comitant findings. So always pain abdomen. So I was very curious to put a scope inside. And on diagnostic lab, this is the finding. This is the finding on the diagnostic lab. There is absolutely, you can think that putting a scope, you can find either a tuberculosis or a malignancy. I think tuberculosis or a malignancy, because everywhere you find the nodules for that. It's not a vesicle, so tuberculosis is not but this is all, it could be a malignancy. So then we did that, explored everything, abdomen, pelvis, everywhere. We explored that and found out that not only in the peritoneum, omentum, and the gut, the intestines, everywhere there is studded with the lesions, and unless we do a biopsy, we cannot be confirmed for that. So these are the very rare cases where we have taken it for biopsy, and biopsy confirmed that it is a case of leiomyoma. Of course, the malignancy and tuberculosis, there could be ascites. The one reason suspicion is that the ascites is not there, and from the history we can find that it is a recurrent myoma. Myoma is not leaving this lady even after repeated surgery. It has gone from pelvis to abdomen to chest. Even lobectomy is there for that. So therefore, this particular case, they see that there is a myoma again in the omentum. In the omentum, you can find a myomatous nodule about 3 centimeter, and you just send the biopsy. You cannot be assured, but suspicion of malignancies after excluding that there is no ascites and seeing the clinical profile of the patient, we thought that it could be myoma, and we have read in the books rarely intraperitoneal leiomyomatosis, and this could be intraperitoneal leiomyomatosis, and this myoma we send it by biopsy, and then we confirm it that is a leiomyoma for that, and that is the rare situations where you find it, and this is one of the rare situations. So what is the treatment now? How can you relieve the pain? Can you remove the all the myomas? There is no scope of surgery here excepting a diagnostic. Medical is most ideal for that, but efficacy is a very important thing. Taken ulipristal acetate for 3 courses, and again relieved from symptoms. Therefore, even if we know that repeat diagnostic laparoscopy, review laparoscopy, I have not done it, but the patient is symptomatically relieved after the medical management. So there is no scope of surgery here, medical management. So you have to decide whether to treat and how to treat medically or surgically. Each individual patient's profile will determine you the indication for treatment and what sort of treatment you do it, whether myomectomy or hysterectomy or some other treatment for that. Now, this is another case, 45 years, para 3, all spontaneous vaginal delivery, menorrhagic cycle with perception of lump abdomen, uterus was 20 weeks. sonographic evidence of multiple myoma. And the patient wanted to do, I think, need for hysterectomy. Patient wanted a hysterectomy, and I was over enthusiastic. I thought if it's a Myoma uterus, I can do it vaginally. If it's in other cases, I cannot do it. So medical management, there is no place. And this is a case where I've gone for the abdominal hysterectomy. Now, in abdominal hysterectomy also, why I pointed this particular case in myomectomy session is that in some of the cases, we are doing a hysterectomy. Even if you are doing an abdominal hysterectomy, you have to do a myomectomy first and then do a hysterectomy. Because you cannot do a hysterectomy if there is a myoma in the broad ligament. There is a chance of injury to the ureter. Remember that if there is a myoma in the broad ligament, do a myomectomy first. If there is a cervical myoma, do a myomectomy first, then do a hysterectomy. And do preferably a bisection of the uterus is necessary in a central cervical myoma, and then do it. If of course, these are the indications where myomectomy is indicated. And third indication, if the size of the uterus is very, very big, it is not amenable to do it, even you can do a myomectomy, make it short, and the bulk of the myoma, the uterus is reduced, and therefore you can do it with that. So this I'm doing with the bipolar vessel sealer, and this machine I'm using it, and with the bipolar vessel sealer. But with the 20 weeks also, you can coagulate the vessel. And remember that in the hysterectomy, you always do a myomectomy after the uterine has been tackled. But everything is not possible. If the myoma is towards the cervix, you have to do a myomectomy after that. And then you do a bisection and remove the myoma for that. And a big myoma is much better than adenomyosis, because it's very easy to enucleate the myoma. Even if the size is more, you can deliver it. But in adenomyosis, debulking is much more difficult. You have a bisection and find out where the myoma, locate where there is a myoma. At least if a space is found out, you find that this is a space, you can apply particularly the myoma screw to find out the cleavage for that. So with the myoma screw, if the big myoma is there, with the myoma screw, you just find with the cleavage, and then putting a traction and a counter traction by the myoma screw and counter traction by your Caesar, you can deliver the myoma. Again, one myoma is there. After that, you can again go and find out another myoma, big myoma, because it's a 24 week size uterus, multiple myoma is there. You can again locate another myoma there, and then again putting a traction and a counter traction. This is a Caesar which have really dissected the space, and particularly find out the cleavage. And then with the cat's paw, you just put a traction along with the myoma screw, and just with the Caesar, you can just drag it down and see if you're going to the proper cleavage, absolutely whole thing will come out, even if it's a bilobed or multilobed myoma for that. See, the big myoma is again coming by just giving a traction. This is very, very important that myomectomy, you do it and then facilitate hysterectomy for that. So this is purpose for which I projected this. This is a case of hysterectomy, but myomectomy facilitating the hysterectomy for that. So the controversies and consensus, again, the Caesar and myomectomy I have already told. Laparoscopic myomectomy with changing trends and changing techniques, I have already told about the use of 3D, about the skill of the surgeons, about the suture material of a barred suture is really help for that. And laparoscopic myomectomy is very important. The suturing technique should be learned by endoscopic surgeon, and the suture can help it in replace. And nobody now, everybody is using shifted from the conventional vicryl to the barred suture. And hysteroscopic myomectomy, changing trends and changing techniques. Earlier, the hysteroscopic myomectomy again is limited to the grade 0 or at best to grade 1. Now, with the skill of the surgeons, with the very good visibility of the SPICE camera, and we can distinguish the myomatous tissue from the uterus myometrium. Cleavage can be identified, and we can also deliver it going through the deep into the intramural component, and even up till about grade 2, we can enucleate it through the hysteroscopy. And that's much better that you go through that rather than going for the laparoscopic myomectomy for that. And of course, I have again told that abdominal myomectomy is also a place in minimal invasive surgery. And I have dealt with the ulipristal acetate. There are some indications of ulipristal acetate, but it cannot be a substitute for the surgical treatment for that. And same thing prior to the ulipristal era, we are using the OCP and the GnRH analog. And of course, mifepristone is also an alternative to ulipristal acetate. I've dealt with these alternative methods of uterine embolization, MR focus ultrasound, and Mirena, which are in one of the cases we have shown that. Power morcellator, the genesis of sarcoma, pre-treatment evaluation is necessary. In-vag morcellation, I think these are all myth versus reality. Americans are very, very scared of that nowadays, so that a lot of American patients come to India to get operated by Indian surgeons and then go back for that. So where is the question of damage to the power morcellator and the legal shoot? But it is just a crazy Americans and genius Indians, indigenous methods, they use it and deliver the good, particularly for the benefit of the patient. So the take-home message, myoma is the commonest benign entity in females, varying spectrum of presentations from asymptomatic to symptomatic, fertility attribute difficult to explain, treatment modality, expected medical and surgical methods, search for newer molecules, trained towards conservative surgery and organ preservation, MIS of endoscopic surgery, technical innovation, sarcoma, myth versus reality, controversies and consensus defined, and then future thoughts could be there for that. Now I have already covered all these because it's a surgical session and surgical skill transfer. Just I put few of the videos and you can see these particular case for that. And this is one case where we have already seen the vaginal myomectomy, particularly for that. And this vaginal myomectomy, this is a case where I was telling about that Rh negative, 5.2 gram hemoglobin, and with the myoma, same thing. The same type of case is this, and this is a bigger myoma. The sonography says there is a large cervical myoma of about 12 centimeter diameter, but only the tip I can visualize, only the cervix external os is little dilated, and only the surface of the myoma I could locate it for that. So with that, I proceeded that particular case, and even with that larger myoma, see the same procedure as in the previous slides where giving traction and counter traction. You go with this and deliver the myoma through the vaginal route, and this is a very good method for vaginal myomectomy for that. Remember that this is a case where it could be very well done for that. And see, the major component is inside the uterine cavity. It's not only in the endocervical. See, the large myoma and bilobe myoma can be there, and the operation is finished for that. And whole thing is being done with the minor, and hysteroscopy is done. Hysteroscopy absolutely normal. There is no other myoma for that. So we are rest assured that the treatment is completed and the patient is having a very important recovery for that. Now, this is another case, another big cervical myoma. Diagnosis of cervical myoma by ultrasound. Patient presented with acute retention of urine. Indwelling catheter has been given quite often, and on examination I find that I couldn't find anything. The cervix was not seen. Whole thing, the vagina was filled with that farm mass, but the upper pedicle was not seen. It was a large, it was arising from the posterior lip of the cervix. I gave an incision on the posterior lip of the cervix as in my previous case, but this was a huge myoma. This was a huge myoma. This is arising from the cervix. And then I gave an incision, and then again the same procedure which I did it. And you can see the main trick is that going through the proper cleavage. I think if you're going through the proper cleavage, things are very easy for that. And you can see that absolutely good. With the simple traction and counter traction, see how big a myoma can be delivered with that. The earlier case was, I've shown a small cervical myoma in my previous video, but this video you can see as you go down and down automatically with the simple traction that will come out, and just guide it and everything will come out. It's a large myoma and it could come out with that. And this is a cervical myoma. From below, this patient was planned for hysterectomy, abdominal hysterectomy for that. And see, just a cervical myoma arising with that, and a large myoma of about 15 centimeter diameter can be delivered with that. And then reconstructed the cervix, and absolutely patient is all right for that. So this is method of cervical myoma. This is another interesting case which I will also say. This is a case presented with about 11 weeks pregnancy with severe pain abdomen, and on examination I find that yes, pregnancy was intact, a single live fetus was there, but it's a pain abdomen, and there is a hypoechoic mass, and it is not a cystic mass, and therefore the pain abdomen. So it was not linked with the uterus, was completely separate on ultrasound. And then we thought of adnexal torsion, and then the conservative methods was being given. But earlier, the sonographic picture came that it could be a hypoechoic area, it could be myoma, and therefore we thought of a red degeneration. So the patient didn't improve after conservative management, severe pain abdomen and all that. So therefore, we are bound to do a laparotomy. So in the laparotomy, I find that there is a big subserous myoma arising from the fundus, and it has undergone little torsion, and that's why the cause of the pain is there. And then I did during pregnancy of 11 weeks, I did the procedure of laparotomy and myomectomy, and give the progestogens and continuing the pregnancy. Fortunately, God has helped me. Pregnancy has continued. Patient is relieved of symptoms for that, and big myoma can be delivered. And pregnancy antenatal care continued, and patient had an uneventful vaginal delivery after that. And that gives me a lot of satisfaction that really, believe me, I've seen 2 cases of pregnancy with myoma where I've done is a myomectomy particularly for that. And this is another case where it's a grade 1 or grade 1 myoma, where I will show the submucous myoma, where hysteroscopic myomectomy. I think myomectomy, I have already shown you that particular previous video. This is another video where immediately you can find a laparoscopy also, because laparoscopy also, if there is any other lesion, we can find it out for that. Now, in a grade 1 submucous myoma, I plan for hysteroscopic myomectomy. And the main thing which I was telling you, that gone at the situation, in the early phase, we are doing only 0, and we are leveling it to the level of the endometrium, into the cavity. Earlier, in the procedure, in the initial part of my practice, I was doing with the leveling it. Then subsequently, during the procedure also, if there is an intramural component, it could bulge, and you can do it. And in the second sitting, again, there is a bulge, you can do the same procedure for that. But instead of that second sitting, you can completely deliver it, because the camera can show you whether the myomatous tissue and the uterine tissue, whether this is there or not. If the uterine tissue and the myoma and the cleavage can be completely visualized with the recent camera, particularly the chroma and clara, and therefore with the SPICE camera of chroma and clara, the distinguishing feature between the myomatous tissue and the normal endometrium and the cleavage is clearly visible through hysteroscopically, through the camera. And therefore, I can show you that this is very important. It's again through that, it's a grade 1. We have gone deeper into it, a cavity. Inside the cavity, still there are myomatous tissue. You can see that there are still myomatous tissue, and we can gently deliver. Now you can see this is the particular situation where you can see that this is the tissue which has lifted that. So this is the particularly, now I can find that we have gone deep into it, the cavity, and find that this is to be completed and completing the procedure. So this one I wanted to show you, particularly that in grade 1 or 2, we can do it also with the hysteroscopic myomectomy. This is another case where we can do that. We can another case we can do again the same procedure for that. The procedure is same, but remember that we have shifted to the bipolar. Now, if there is a small, what are the techniques of hysteroscopic myomectomy? Hysteroscopic myomectomy can be done by this procedure of resectoscope, either resectoscope, unipolar or bipolar. Now, bipolar is a must, endomet is a must for that. Second option is if there is a small myoma in the submucous myoma of about 1 centimeter, 2 centimeter, you can have a Warsaw point, bipolar electrode. The Warsaw point has been the separate instrument which be available by Johnson, but it is only restricted for smaller submucous myoma. It can fulgurate it. The tissue cannot be obtained for that. It can fulgurate. You cannot send it for biopsy. But in larger sizes, you cannot do it. and that's very difficult for that. And therefore, hysteroscopic myomectomy by bipolar is much more better for that. Now, because of the toxicity of the unipolar electrode, we have shifted to bipolar. Even bipolar, I've already told that even if you are using the normal saline, check for the the pulmonary edema. Check for congestion. I think chest congestion and the output intake output chart balance, it has to be maintained even if we are using the normal saline for that also, because ammonia toxicity may not be there, but there could be a pulmonary edema. Now you can clearly identify. I'm just showing this video because you can identify and distinguish between the uterine surface and the myoma. This is the uterine and this is the myoma. And now we can find that yes, completely it has gone out for that. So this is how you do it with even with the grade 1 and grade 2. You can do the hysteroscopic myomectomy. There's a lot of advances in the technology so that we can do it in one sitting rather than 2 sittings for that. Now, this is another case. This is another case which I will show you, that this is another method of hysteroscopic. This is a saver system. That means no current is being used, no resection is being used. This is devised by a saver system, and this is a mechanical morcellator. Mechanical morcellator, and it will rotate 180 degree. This is devised by these storage people, and it's connected through the suction device so that it will grind. It will like a grinder machine, and it will grind it. By rotation of that, only normal saline, and no current is there. No chances of absorption is very least with this, because these are all these small saver system. It is just churning the tissues and grinding the tissues by movement of this instrument 180 degree, and that is also very good. And this is an alternative for hysteroscopic resectoscope, and no current is necessary for that, but it is again limited. That very large myoma of more than 4 centimeter, it takes a lot of time for that. But smaller myoma less than 4 centimeter, you can do it with a single sitting and with accuracy and all that. Only demerit is that you cannot send the tissues for biopsy. You can have a cytological with the collected gravels, collected tissues along with the normal saline. You can send it, but it is not akin with the tissues histopathology section. That is the demerit. But this is another. So hysteroscopic approach, either by resectoscope or by the Johnson's bipolar instruments, and this is another saver system by purely non energy source is not required, and this is can be tackled with a small size for that. So the bipolar resectoscope in a bigger size uterus, bigger size myoma is much more preferable than the saver system or the bipolar by the Johnson people. Now this is a case where we find it's a big myoma with a lap myomectomy. The decision is again anterior. The common tricks of lap myomectomy is that normally the vasopressin has to be there, and just find out, survey of the myoma where it is, and uterotubal junction, the anatomy, that's very important for that, so that the incision could be there, and it's a fertility promoting surgery. You cannot go. And this is a vasopressin needle with the vasopressin. Remember that the vasopressin, we don't go all around. Earlier we used to go all around multiple punctures, but single puncture is much more better for that. Single puncture, you push it about 100 to 200 cc, and a transverse incision, taking very care about the uterotubal junction for that. A transverse incision, because the transverse rather than longitudinal. Transverse is much better for the closure, because longitudinal is very technically, ergonomically, it is not suitable for suturing. So the transversely, and here also the same principle of overcutting, as I have already told, overcutting, so that you can find the cleavage, and then you can find the cleavage, and then this is the cleavage where you find it, and this is the overcut of the myoma. Some of the incision you can find it out, and therefore either by the myoma screw or by the tenaculum, laparoscopic tenaculum, you catch hold of this, and all around you go to the proper cleavage with the myoma. This is a myoma separator. You can use this myoma separator, very mechanical, and it's all good. And if you are going to the proper cleavage, believe me, you can deliver the good with the list of bleeding for that. So people are apprehensive that myomectomy causes a lot of bleeding, and this hemostatic preoperative injection of vasopressin can help it. And vasopressin, I have already told about the monitoring. Just be careful about the monitor, and appropriate time you give. If there's a bradycardia, you can use the glycopyrrole or atropine to find out that particularly. So the big myoma can be delivered easily with the laparoscopy, but it depends on the skill of the surgeons. I cannot say that every surgeon has the limitations for that, but remember, you cannot compromise the life of the patient or the damage to the patient. At the cost of the patient, you should not show your surgical skill that I have delivered it, the 2 kg myoma for that also. So that is very important. It depends almost on the skill, the gadgets, and the patient's profile, the site of the myoma. All these are matters for that, concern for that. And therefore, it always depends on you as well as the patient to determine the technique of. But there are a lot of changing techniques on the techniques of the procedure. I think I've used the 3D camera has also improved the visibility, and therefore the 3D camera can differentiate the cleavage as well as the suturing is much better with the 3D camera for that, so that you can see clearly, and layer by layer you can have a suturing. 2 layers you can good suturing for the integrity of the scar in future, so that if for pregnancy and even for the vaginal delivery, it could be possible for that. So these are the techniques for that, and you go for a proper cleavage. And there's another myoma in the front, and you can with the same incision, you can deliver this myoma also and close it after that with the dead space closure for that. Now this is again a conventional abdominal myomectomy. This is a large myoma of about 30 week size uterus. Uterus is 30 weeks, and giving the pun and still incision. I'm not going for larger incision for that. People prefer longitudinal, but even large size uterus can be delivered with that. So this is an abdominal myomectomy where large size uterus can be delivered, and you see myoma screw can be used. The vacuum can be used for lifting the myoma and delivering it from to outside. And if it is not delivered, even you can do a myomectomy in situ and then deliver it. Now with the myoma screw, I have kept it and just delivering it, and the whole of the myoma can be delivered it completely. And this is a method by which abdominal myoma. So I say that in my view, the dogma, I don't believe in dogma in science. I say that is there is definitely a place wherever there is an indication for doing a abdominal myomectomy. I will not say that yes, it's only laparoscopy. I don't think that this is really true, or only laparotomy. That is also not true. It's depending on your clinical skill, depending on your clinical profile of the patient. This is, but this is a very easy case. After that, after delivering, now we find that this is a subserous myoma. I've shown you in this particularly previously. Just one subserous myoma in the arising from the fundus, and one another subserous myoma. This one is a pedunculated myoma, another is a sessile myoma, and the pedunculated, and you can see the beautiful survey of the uterotubal junction. I think that's important for giving a incision for that. So that point I want to show you, that you select the point where you can give an incision so that you don't damage the uterotubal junction and affect the fertility for that also. So that is very, very important for that. So for that reason, I'm showing this. This is another case of abdominal myomectomy where a huge myoma of about 32 week size uterus. This is there, but single myoma, it can be delivered. I don't dare to be that doing it laparoscopically. But here the posterior myoma is there, and the tube and see the tubal opening is tubes and ovaries can be clearly seen. Again, the same principle of overcutting, and with the myoma screw, you can deliver the absolutely the whole thing for that. And this is very, very important for that overcut the tissue and find out a particular cleavage, take care of the uterotubal junction and good anatomy. And then like a coconut peeling of the coconut, I think you can do it with that. Same if you go to the proper cleavage, it could be very well delivered with the list of bleeding for that. And here You can use if it's a large myoma and if it is above the cervical, you can use a tourniquet. We still use after the drug vasopressin. We are not using much of tourniquet, but still tourniquet earlier to vasopressin, we are using the tourniquet and the cervix and tying it with the number 8, the infant feeding tube, and that gives a very good result for hemostasis for that. So whole thing can be delivered. You can see that if you are going to the proper cleavage, number 1, bleeding is less. Number 2, the cavity is not open. You can clearly see above the cavity because it is completely an intramural myoma, and it can be. So earlier videos I have seen that it's a case of subserous myoma. This is an intramural myoma, which is little difficult than the previous case. And you suture it, and redundant portion you just excise, and the other cases you suture it for that. Thank you very much, my viewers. I've taken a lot of time in my presentations and videos for the benefit of you, and this is last suggestion and feedback. Dr. Diwan, thank you very much for bringing this topic today in this episode of myomectomy, and I've created a lot of the controversies also, solved many of the controversies, and I can transfer my technique to my fellow delegates and fellow gynecologists and have a feedback and suggestions and queries if they like for that. Thank you very much.
It was from our side, first of all, thank you so much. It was an excellent collection of your surgicals, surgeries you have done, and it's a personal experience which you share with all the practical approaches with your students, and we all are students. So thank you very much for all this lecture. And as usual, you have a lot of queries which you need to answer probably now one by one. So I start with the first query from Dr. Harshita of Nagpur. She's saying, what is the cutoff size for hysterectomy, hysteroscopic myectomy? Sorry.
Now, that's a very tricky question. The hysteroscopic cutoff size for hysteroscopic myomectomy. Believe me, my cutoff size, I restrict it to about 5 centimeter. And beyond 5 centimeter also, I'm going for hysteroscopic myomectomy in different sittings. So my cutoff size for submucous myoma 5 centimeter in single sitting would be like that. And if it is a grade 2 and a grade 3, suppose I find that it is a grade 3. After operating, I find that initially I was thinking that it's a grade 2, but it's a grade 3. Now I will stop that procedure and again do in a second sitting. The grade 3 will be grade 2 or grade 1 for that. So repeated sittings I will do it for that.
Right. Okay, there is a query from Dr. Vandana Shetty from Mumbai. She says that a 24 years old unmarried girl with 6 centimeters subserous fibroid with menorrhagia can be treated with medication or laparoscopic myomectomy is required. What is your preference?
I think 6 centimeter, 24 years unmarried with subserous myoma. I think subserous myoma, I think it's better that you do it the laparoscopic approach because it's feasible. Now the question comes, if it is a 6 centimeter myoma, intramural myoma, and particularly grade 3, grade 4, these are the cases where the alternative is you can go for the medical management, and this can be a temporary purpose. You try with the medical management. If it fails, then you can go for surgical. I think surgical is not the beginning. From the beginning, it's the only answer for that. You can go for that.
Sure. Okay. There's a query from Imphal by Dr. Purnima Pram. She's saying that intracavitary myomectomy can she carry another pregnancy? Will there be uterine dehiscence in later trimester?
No. I think uterine dehiscence will not be there in the next. Rather, uterine dehiscence is more common if you go from outside. If you go in a separate incision from outside, uterine dehiscence is more common. If you go from that below, uterine dehiscence, you compare with the hysteroscopic myomectomy. We are in hysteroscopic myomectomy, we say grade 2, we are doing it for that. What we are doing, we are keeping that. And here the added advantage is that you are suturing also. You are suturing, not that you are doing a hysterectomy the cesarean myomectomy and leaving the cavity open. If you leave the cavity open, they're not bleeding, you can leave the cavity open. But even if it's not bleeding, we have to repair that on that muscle layer so that for the tensile strength of the scar will be better.
Okay, right. Sir, Dr. Vandana Shetty again has asked a query that from Mumbai, that what should be the criteria for myomectomy during LSCS? An asymptomatic 4 centimeter intramural myoma ought to be removed if seen during LCS, or can it be left?
Now, if it is an intramural 4 centimeter myoma, you can leave it. There is not a problem for that.
Okay.
I think you have to find out whether the myoma is a sufficient size, more than 5 centimeter, and any size in the cavity. Suppose 2 centimeter myoma, submucous myoma. You deliver the baby and you find that there is a myoma in 2 centimeter myoma. You better remove it. Otherwise, the immediate post-operative, there will be a problem of bleeding. You think that it could be a retained product of conception or placental tissue, and that you must tackle it and all.
Okay.
But there could be a even subserous seedling myomas, multiple seedling. Don't touch. If there's a multiple seedling myoma, don't touch it and remove it by cesarean section. If there, that's why I told that if operation is indicated, there is a sufficient ground for indication of myomectomy, then do the cesarean myomectomy. Don't operate for that.
Okay, right. So the next query is coming from Bhagalpur. This is Dr. Leena Nair Lal. She's
Yes,
saying
Leena.
that what suture do you use for intracavitary closure?
The same intracavitary closure, we use the vicryl and number 10. Number 10 is enough for that vicryl. We don't use the barbed suture here because barbed suture is restricted only for the laparoscopic approach because it is much better. Technically, it's much better. Surgically, it's much better for that. But it's costly. And therefore, the same, its material is same. But the barbed suture is more costly. The material is again a vicryl for that, vicryl. So vicryl 10, I will use it for intracavitary closure.
Okay, okay, right.
You can use also a catgut, there is not a problem.
Fine, sure. So the next query is from Navi Mumbai. This is Dr. Vrishali Kamale. She's saying that at 37 years old, family completed female, right lateral intramural 7 centimeter fibroid. The cycles are regular but heavy. So cavity is normal, responding to ulipristal for bleeding, but there is no reduction in the size. So what should be done?
We know that myoma is a benign condition. Myoma of 7 centimeter, asymptomatic, don't touch. Right. Even if the family completed 7 centimeter, just a follow-up for that. But here, the menorrhagic cycle, bleeding is less. If the bleeding is controlled by simple tranexamic acid, maintain that. Don't do a surgery. Don't do a surgery. Right. If it is not controlled, then you can have a medical management, which can be a temporary purpose or a surgery. Surgery is the last resort in that particular case. But if there is a torrential, if the menorrhagic symptoms are profuse, heavy, not responding to the medical management, certainly you have to do that.
Sure. Sir, there's a query from Bhubaneswar itself, Dr. P.K. Acharya, asking that what is the guideline for ulipristal therapy?
The guideline for ulipristal have been used, abused, and misused. Initially, when ulipristal and these Dynogest, these are the two molecules which came up in the same time, and people thought that gynecologists thought that a wonder molecule has come out, and the pharma people has also infused an idea that as if it is a wonder molecule and it is a substitute for the knife. It's not a wonder molecule for that, and ulipristal is definitely, it can reduce the size of the uterus. Guideline of this, say for example, when the surgeries cannot be done, and as in case where I've shown you that leiomyomatosis, multiple myomas, particularly unmarried, infertility, not conceived, not married, and adolescent. These are the cases ulipristal you can try for that. Otherwise, ulipristal is not a wonder molecule for that. And recurrent myoma, these are again indications. These are some of the guidelines for ulipristal.
Sure, right, sir. Okay, now one more practical scenario is being asked from Champa. This is Dr. Saurabh Barthare. There's a patient with regular menstruation, normal flow for 3 days, single myoma in anterior wall of 1.7 by 1.3 centimeter. Whether to give medical treatment or surgical lap myomectomy, her rest, all our investigations are within normal limits.
He is asymptomatic, cycle is normal, 1.2 to 3 centimeter. If you want to earn money, you do the whatever you like it. But I think for a genuine reasons, for ethical reasons, don't touch, don't give it, just follow up, don't treat. You convince and counsel that this is a tumor which is absolutely benign. It doesn't need any treatment, neither medicine nor surgery.
Right.
And give my fees.
Sure. So there are a few more queries if you are able to take.
Yeah.
Okay. There is Dr. M Shivadayal from Medak. What is the myomectomy scar measured if the patient, sir, is myomectomy scar measured if patient is pregnant?
Couldn't follow. Myomectomy scar measured.
Yeah, so the query is like this, that he's writing that is myomectomy scar measured? Do you measure it if patient is pregnant? I really couldn't understand myself.
Yeah. Maybe that I could think what she is meaning.
Yeah.
Maybe that like cesarean scar thickness.
Right.
You do a measurement of the cesarean scar thickness by sonography.
Right.
And whether the scar is thin or thick or all that, to say that this is liable for rupture. I think there are more studies which shown that even myomectomy, even cesarean scar, the thickness and the liability for rupture is not very well correlated. Even thicker scar can be liable to rupture. Even thinner scar is not liable to rupture also. But thickness is definitely a matter of concern for that. So when there is a myomectomy, previous history of myomectomy, you are doing a ultrasound and you must see that particular segment where the myomectomy is, that the whole area, when you find that the myoma, the uterine muscle, some area is absolutely thinned, then you can see that yes, it could be a myomectomy scar, and that is a point where that could give way for that. So that could give a suspicion for that.
Right.
And thickness is there, and this is important also.
Right, sir.
Two things are important in a previous myomectomy sonography. You locate for the placenta, whether the placenta is attached to the myomectomy scar, giving rise to the adhesion or morbid adhesion. Second important is the thickness. But there is no measure to find out, no instrument or no gadgets to find out the integrity of the scar. Even cesarean scar also, where there is no measure to find out the integrity. Till date, we do not have anything.
Right. Okay, so the next query is from Imphal. This is Dr. Ekpam Wongol Lima. She's asking, please give your suggestion on a second gravida post-cesarean section, 16 weeks pregnancy with large anterior wall cervical myoma, 9 centimeter each size, having acute pain.
Now, if it is a cervical myoma with acute pain, think of red degeneration first. I think conservative management is to be done first. And majority of the cases will settle and pregnancy will continue. And delivery, maybe that you can do a cervical myoma. Even cervical also can be, there is a place for vaginal delivery. But in cervical myoma, you have to, because of the obstruction and all that, and malpresentations, you have to resort to a cesarean section. And then and there you can do a myomectomy for that. Otherwise, I think majority of the cases will respond for that.
Okay.
Only thing which I quoted in my own patient is a case where it's not responding. 11 weeks pregnancy and there is a mass and ultrasound demonstration of a hypoechoic mass, either a solid ovarian tumor undergoing torsion, and that's the most probable diagnosis. And on laparotomy was done because it was not responding after 72 hours. Also, patient was rolling with pain abdomen. I had to do that. Otherwise, it could not have been sought for that. So this is only indication when it is not responding.
Right. Sir, from Varanasi, this is Dr. Poonam Gupta. She's asking, can Mirena be used if multiple small intramural fibroids up to 12 week, size up to 12 week?
I have demonstrated the same thing. The patient para 2 both cesarean section. That was my clinical profile I have laid down in the clinical situation. That para 2, previous 2 cesarean with multiple seedling myomas, and uterus was about 10 to 12 weeks. And Mirena could be an option for that. And there you have to do a hysteroscopy to find out if there is a submucous myoma, it is not going to respond for that. But Mirena is definitely an alternative for that.
Right, sir. Sir, from Bangalore, there's a very practical question from Dr. K. Ganesh Bhatta asking that what is your advice for adhesions prevention?
I think a good piece of surgery and the patient's profile are both responsible for that. Patient's profile also is very important. Wherever the adhesion, the pathogenesis of adhesion is a $1 million question. We do not know what is the cause of adhesion. But a good tissue handling is important. Hemostasis is important. And patient's profile, of course, is important. Even if we have done a good surgery, also we find there could be adhesion. And we have a lot of adhesion prevention strategies, starting from peritoneal toileting, irrigation, normal saline, to some of the barriers, adhesion barriers we put it, and interseed and all that. I've used that. Even laparoscopic myomectomy, initially I was using all cases after laparoscopic myomectomy and interseed for that. And lot of studies also demonstrate that it's not very certain or crystal clear that adhesion prevention could be there, but it could be some effect for that. But primarily I will give emphasis on a good tissue handling and a good suture without hemostasis, with hemostasis and all that could serve a very good purpose for that.
Right. Or sir, any other like oral medications post surgery you give for like some enzymes or something?
Adhesion prevention enzyme doesn't help. Maybe that now this is a food for thought for the one that you find out a novel drug, and so that adhesion prevention would be there, and it could be really a $1 million business for Juventus people for that. And people and Mr. Gua will reward you definitely. Think about it. And I was really every surgeon, gynecologist are thinking of effective adhesion prevention agents. Systemic, if you give it systemically, nothing like it. But that is a big question mark. Like now, we find immunobooster. Everybody is thinking immunobooster in corona, and whether you can say that it's a very good thing and concrete thing for that. So this is really a gray zone.
Sure.
Dr. Devan, you think about it, adhesion prevention, there is a lot of research should be going on that, and think about it. Till today, we do not have adequate adhesion prevention agent.
One thing, right.
Even placental extract has been tried for that also, and all that systemic, and we cannot say that it's a optimum for that. Scientifically, we cannot prove it.
Sure, sir. Sir, continuing with the same kind of prevention, like now it is prophylaxis or precaution in case of vaginal myomectomy. So how to reduce bleeding in vaginal myomectomy?
Vaginal myomectomy, I have shown that either a myomatous polyp, you just avulse it, bleeding will be controlled. The vaginal myomectomy, second case I saw that vaginal myoma arising from the cervix. I think bigger size, even if it's a much bigger, you go to the right cleavage and with the vasopressin also, bleeding will be controlled for that. And if it is a endocervical, it's coming from the endocervical canal, like the other case I've shown you, a big myoma, when only small area is visible and the whole myoma is inside the endocervical and cavity, big myoma about 12 centimeter. There, you just avulse it, clear it, and bleeding will automatically be controlled. Sure. You need not coagulate the pedicle and all. Don't search for the pedicle.
Okay. Okay. So there's a query from Hyderabad by Dr. Uma Devi that there is a gravidate 2 with previous lap myomectomy. Yes. What is your mode of delivery with this? Previous was the normal delivery.
This is again a confusing question and all that. It's very difficult to answer because I remember 15 years back when I was going as an examiner and asking the postgraduates, what are the indication of cesarean? They were beautifully classifying fetal indication, maternal indication and all that. Now I am going as an examiner. The examinee are so talented and smart They are telling, sir, presence of pregnancy is an indication of cesarean section. So presence of pregnancy is an indication of cesarean section. Presence of uterus is an indication for hysterectomy.
Wow.
If obstetrics and gynecology is so simplified, if with the previous lap myomectomy, what is the next thing to do it? Well, scientifically, I'm telling you, if there is a previous history of lap myomectomy with the previous vaginal delivery, if everything is normal, there is no contraindication for vaginal delivery. That's very important for that. But you must be, because you must find out what is the type of lap myomectomy. Like I have shown you, lap myomectomy in a subserous myoma where absolutely uterus is normal. I think it's as per the normal non-myomectomy case, you proceed with that. But if it's a intramural myoma done with that, multiple incision has been given, and in that particular case, the chances and risk of rupture is there, and there you can go for a cesarean section. Otherwise, there is no contraindication for vaginal delivery for that. But if you want that, yes, we don't want to take any risk, patient doesn't want to take any risk, then it's all right. But scientifically, there is a place for vaginal delivery.
Sure. Okay, sir, from Sambalpur, Dr. Benudhar Pandey,
Yes.
the query is that can hysteroscopic myoma shaver will substitute bipolar hysteroscopic resection in future?
I think it cannot substitute. These are some alternative methods. Say, I have already told, saver has been there because energy source should not be used. That's one point. And absorption of fluid should not be there for that. But saver has the limitations also. Saver is a mechanical thing. I have already told that up till 3 centimeter myoma, saver can be used very well. It takes a very important. But a larger size myoma, even 5 centimeter, 6 centimeter myoma, it cannot be compared, and it takes a longer time. And also, it's compared to the bipolar resectoscope, it is inferior. And only in a smaller size myoma, it is an alternative for that, like a Versa point. Versa point is the same thing. Versa point, bipolar Versa point also is a 2 centimeter myoma, 3 centimeter myoma. You can, small polyp-like thing can be tackled with the Versa point. So it cannot replace the bipolar resectoscope. Rightly you have pointed out, and I feel that these are some alternative situations for that.
Right. Okay. Sir, from Lucknow, Dr. Seema Mehrotra, she's asking anterior wall myoma during cesarean, how to give incision for intracavitary myomectomy?
Well, the problem where you find intracavitary myomectomy easier, closer to the cervix, the myoma is easier is the procedure. Away from the cervix, closer to the fundus, difficult is the procedure. So anterior myoma, it depends. It could be difficult, but retracting the cut end of the uterine incision with the retractor, you can see the anterior wall, and you can find out where is the, if it is high up in the fundus, it is not possible. Don't try, therefore. So anterior myoma and posterior myoma in a uterus of about, after delivery, it comes about, say, about 10 centimeter, 12 centimeter. With that also, with the retractor, you can approach the anterior myoma, anterior wall myoma, and deliver it. If it is not approachable, don't try from the intracavitary further. That is the two things is that deep in the fundus, if it is there, not projecting to the cavity, more of the type 3 and type 4, and subserous variety. These are not amenable for intracavitary. Rather, majority of the cases are in intracavitary.
Okay, sir. Can we take a few more questions, sir?
Yeah, I'm free.
Okay. Sir, there is a query from Chennai by Dr. Sailata Ramanujan asking that what is the dilution of vasopressin that you recommend?
Vasopressin is available as 20 units and 40 units. And 20 units per 100 ml is the minimum thing. You cannot go below it. 20 units per 100 ml, or even you can dilute it more, up to about 150 to 200 ml can be better for that. But this is important that 20 units, less than 100 ml, don't use it. You can increase to 200 ml also. There is not a problem.
Right. Okay, sure. Now, sir, another query which I'll like to highlight over here. It is again from Imphal, Dr. Lima again. asking that after how many months of intramural myomectomy can the patient get pregnant?
See, the question of recovery is not determined by the duration of pregnancy. After cesarean, even the same question you ask yourself, after cesarean, doing a cesarean, after how many months you go for a second pregnancy? That is also same thing for that. Right. If say for example, patient lost the baby because due to some reason or other there is a neonatal death. So we don't want to prolong it more. So 6 months is a minimum period as per my recommendation. I allow for a minimum period of 6 months.
Okay.
And normally if you go for a theoretically wound healing procedure, wound healing, to complete the wound healing, it takes 18 months.
Okay, all right. That's quite.
So that is the philosophy, that if there is no absolute emergency, you can wait for 18 months for the second pregnancy for that.
All
but
right.
in cases where the patient is elderly and the pregnancy has resulted in a stillbirth or neonatal death, you don't prolong it for 18 months.
Right.
So 6 months is enough for that.
Sure. So from Kolhapur, Dr. Sharvari Mirgunde, she's asking 10 centimeter asymptomatic intramural myoma, infertility is there, bilateral tubal blockage, should myoma be removed?
Well, if it is a 10 centimeter myoma in an infertile patient, tubal blockage, there are two options. Either you do the tubal cannulation, do it, try for a few months. If it's not conceived, then if you think that this myoma could be attributable for that. But the second option is that do a cannulation and myomectomy in the same sitting and then try for pregnancy. These are the two options which.
Okay. So from Vizag, Dr. Lakshmi Kondamma, she's asking like, do you use IVP and ureter stenting in case of large cervical fibroid for vaginal myomectomy?
I couldn't understand. Repeat it.
For
large cervical myomectomy?
Do you use IVP and ureter stenting?
Oh, IVP. So procedure before the procedure, IVP and ureteric stenting, I think it's not necessary. Okay. Because this is not necessary absolutely, because you are going from inside. You are not coming from outside. I think this is not necessary.
Right.
But in the cases of broad ligament myoma, some cases of broad ligament myoma, I think this is important. The broad ligament myoma, IVP will show you whether it's a pseudo broad ligament myoma or a true broad ligament myoma. And true broad ligament myoma is myoma arising from the broad ligament tissue, where the ureter is medial to the myoma. Whereas pseudo broad ligament myoma, the myoma is arising from the cervix and lateral spread is there, so that it will displace the ureter laterally. So this is important in a case of broad ligament myoma, where ureter is going to be affected, where IVP can have it, but stenting is not necessarily required for that. And during surgery also, you can be that extra precaution has to be taken for finding out a cleavage, and that cleavage will save you from the ureter for that, either lateral or medial.
Right.
But it's better that you can know it by IVP, but not ureter stenting is not necessary for that.
Sure, sir. So only two more questions are there, and that is one pertaining to a case of primary infertility with PCOS with single intramural myoma, in posterior wall of size is about 6 by 4 centimeter. Taken 2 courses of ulipristal acetate. Now myoma is reduced to 2.93 by 2.5 centimeter. Whether we can give induction to this patient or repeat another course of ulipristal.
With 4 centimeter myoma also, I will not give a ulipristal for that. See, therefore, the cutoff limit of myoma with relationship with infertility, even ASRM and SG has given guideline and changing the guideline. The cutoff limit of size of the myoma is 5 centimeter.
Right.
But if it is only, it cannot be assured that 5 centimeter is the cutoff limit. Everybody cannot accept that. Also, I am not convinced. There is no logic inside it. But with 4 to 6 centimeter asymptomatic, it's a subserous myoma, cavity is normal, and it is a PCOD where disovulatory infertility is there. I think with that myoma also you start ovulating and start a treatment with the myoma also.
Okay.
Rather than giving a ulipristol, you decrease the size and then start treatment for that. I don't find any justification. Even with 6 centimeter also, I will say that it's a disovulatory infertility. Myoma is not a cause of infertility. I will start the treatment for that.
Okay, sir.
If it is not responding, then the second step I will consider with the myomectomy for that. Otherwise, myomectomy surgically is not there. Ulipristol also can be given if it is symptomatic. If suppose there is a symptoms of menorrhagic cycle and all that with the 6 centimeter myoma, cavity normal, then you can say that yes, even if it's an intramural myoma, it could be producing the symptoms of menorrhagia and ulipristol could be effective for that. But this is a disovulatory infertility. Ovulation induction has to be given along with the myoma.
Sir, from Hyderabad, Dr. Aruna Kumari, she's asking, there's a mid-trimester abortion, posterior wall and broad ligament fibroid, 11 by 9 centimeter. Myoma, please mention the route of surgery, laparoscopy, laparotomy or open? Or laparoscopy or open probably, yeah.
So it depends. I have already told the indication of laparoscopy depends on skill of the surgeon and the profile of the patient, technology. If the technology is available, profile of the patient, he is telling that no, I will go for laparoscopic myomectomy, and you are very skillful that you can do the job, deliver the good, then you will do it. Otherwise, there is no hesitation of doing a abdominal myomectomy for that.
Right. And she has another query, like patient had 2 first trimester and 1 second trimester abortion history of retained placenta. For second trimester abortion, please suggest.
Pardon?
She's saying that there's a patient had 2 first trimester and 1
first trimester abortion
and 1 second trimester abortion history,
yeah,
of retained placenta. So for second trimester abortion, please suggest.
For second trimester abortion,
yeah,
if there is a retained placenta,
yeah,
you evacuate, there is not a problem. The patient presenting with second retained placenta,
yes,
yeah, you just explore uterine exploration and evacuate the uterus. There is not a problem.
Right. Okay, sir. So I think that's such a nice session. I mean, it is so engrossing that.
Thank you. Sorry that due to technical problem, we are late by half an hour. Sorry for that. I have kept you waiting for that. But this is digital is digital and physical is physical, and that's what it happens.
But sir, as far as the enzyme is concerned, we do have an enzyme called as tibrolin.
Oh, tibrolin is an enzyme. Which is given anti-inflammatory along with that.
Yes, sir.
But you promote for adhesion prevention?
Yes, sir. To some people are using it for that. So probably
systemic.
It's oral.
That's oral systemic adhesion prevention. I know that tibrolin, I am using it also.
Yeah.
Tibrolin is effective as an anti-inflammatory rather than adhesion prevention.
Very true.
Anti-inflammatory, I am using it for the normal surgery and all that. Tibrolin.
So actually, there is a tibrolin and tibrolin D. There are 2 forms. One is with the diclofenac. One is plain.
Yeah, but tibrolin versus serosopeptidase. Tibrolin is superior to serosopeptidase as far as anti-inflammatory action is concerned. There is no doubt about it.
Definitely.
But I don't have any idea on adhesion prevention.
Right.
I think that's why I told you, find out a super tibrolin, the one will find out, and I wish that the company will grow within very short time and it will go to a greater height for that.
Thank you.
Find out. I don't have any literature on adhesion prevention on tibrolin.
Sure.
And also, if you want it, if it is systemic or local, we can sprinkle tibrolin into the laparoscopy after laparoscopy and find out and do a study for that, whether it is acting or not.
Sure, sir. Thank you so much for your
Thank you.
Thank you, sir.
Thank you, and waiting for the next episode. If it is feedback is good, we'll go for the next episode. Otherwise, we'll close it.
Right. So, Alad, you would like to say something?
Alad, yes, Alad.
Sir, we are thankful to you as ever for a wonderful session.
It's a bilateral thing, and education is education. I must say that we are even the viewers are most important and the first priority.
Yes, yes, yes. And in fact, sir, I think so most of us are mesmerized by the knowledge and the videos, and we will send with your due permission the link to all those who ask for it once again, sir.
Absolutely. I think education should be spread like anything.
Yes, sir. We'll do that.
I also want a feedback so that I can improve whether I've done a wrong thing or not.
Right,
And that's why I also told you that after all the episodes, have a video and they talk. You record it. I think recording should be there.
We are recording, sir. We are recording.
So it can be in the pen drive also, and you can distribute to all my fellow gynecologists for their benefit as well as for my benefit also.
Yes, sir. We'll do that definitely. Thank you for your service.
Each episode you can distribute as a pen drive so that they can, again, if somebody is not counted, they'll get it. Or link it with the YouTube or with any links you can send it. It is up to you to decide.
So one message I forgot to convey.
I give you permission for exploiting me in any form you like. You can exploit me. Technically, education, as regards education, you can do whatever. I'm prepared to show everything and tolerate everything.
Right, sir. Thank you so much.
One important comment which I missed to convey was that every attendee is praising your work, saying it is excellent, and they are seeking your blessings, sir.
Yes.
So that's why I wanted that whatever my work is there, if I know some surgery, I should transfer it to them. That's why Devan, you have already from the beginning told that surgical skill transfer.
Yes.
This is the Gurukul of surgical skill transfer.
Sure.
Right.
If you can transfer the skill, nothing like it. That's the main purpose for which you can freely give my videos and everything and all that. They can see a number of times and they can practice also.
Definitely, sir.
Right, sir. Thank you so much, sir. Thank you.
Thank you, sir. Thank you. Juventus thanks you for your valuable time and guidance.